there we go.
Okay. Thank you for your patience. I really don't know what the problem was, but okay. I assume this is showing up.
Yes, very well.
Okay, excellent. Well, thank you for asking me to participate. My name is Sid Gospe. I'm a professor emeritus at the University of Washington, child neurologist, and I've worked in the field of PDE for really quite some time, since the late 80s, early 90s. I left the University of Washington in 2017 and stepped down and retired, and have moved to North Carolina to be with family. Have an adjunct appointment at Duke, where I still do some teaching. And I'm continuing to do research with colleagues in Seattle as well as Denver and overseas. And what I'm going to be discussing today is really the phenotype of PDE. And hopefully that this will be of interest to everyone, and we'll have some time for questions, even though a good portion of the hour has been taken up by the technical problems. So let me, for some reason, my slides will not advance, even though you can see them. There we go. As far as disclosures are concerned, I am a consultant for one pharmaceutical company and a content editor for a software company, but these really do not pertain to today's talk. So my goal for today is to discuss the brief review of vitamin B6, pyridoxine, its biochemistry, and the 3 clinical forms of pyridoxine-dependent epilepsy. That's really going to be just a brief part of the talk. And then I'm going to define what we mean by the terms phenotype and genotype. I'm not certain that those terms are necessarily immediately understood by everybody who may be watching. And then really spend the bulk of the lecture talking about the specific phenotypes of PDE, looking at the general clinical presentation of these 3 disorders, discuss some of the biochemistry, and then discuss the various types of seizures and what we call the encephalopathy, which is a term which really means the abnormal function of the nervous system of the brain specifically. Spend some time addressing the neurodevelopmental phenotype of PDE. And then lastly, an area that I've been particularly interested in are the anatomic features of PDE, specifically PDE due to ALDH7A1 abnormalities. So as far as vitamin B6 is concerned, I think a good review is to remember that the term pyridoxine really refers to all 6 of these chemicals that you see in this schematic. But pyridoxine per se is just one of these 6 chemicals, but generically the term is used for all 6. In plants and animals, depending upon the species, one will find a variety of these B6 vitamers. That's the term used for each one of these substances. And what's important to understand as far as the biochemistry is concerned is that they can interconvert from one to the other. But the most important chemical reaction in all of this set of pathways is the production of pyridoxal phosphate, or PLP, because this is the only one of these 6 that is biologically active. And we need PLP for the normal function of a large number of enzymes that affect neurologic function, systemic function of many other organs. Now, importantly, if we are obtaining pyridoxine in any of these 3 forms in our diet, you can see that pyridoxine, pyridoxal, which is an alcohol, and pyridoxamine, which is an amine, will become phosphorylated, which means that a phosphate moiety will be attached to the pyridoxine. You can see that present in all 3 of these, pyridoxine phosphate, pyridoxal phosphate, and pyridoxamine phosphate. And that occurs because there's an enzyme called a kinase that will add the phosphate to each of these three chemicals, producing the phosphorylated chemical. And in turn, pyridoxine phosphate and pyridoxamine phosphate will be converted into pyridoxal phosphate. And again, this is the important cofactor which is necessary for normal metabolism. And abnormalities in pyridoxal phosphate really underlie the symptoms, many of the symptoms and signs of these disorders. So in review, the three forms of pyridoxine dependent epilepsy, there's one that is, best research, best known is known as PDE, ALDH7A1, or antiquin deficiency. This is actually a disorder of the metabolism of lysine, which is an amino acid. And because of the abnormal lysine metabolism, a number of abnormalities occur on a biochemical basis, which secondarily leads to a reduction of pyridoxal phosphate. In other words, PLP is lowered in the cells because of this abnormality of lysine metabolism. And that is the basic reason for all of the signs and symptoms that children and adults with this form of PDE have. Second form of PDE is called PDE BLP-BP, or BLP-BP deficiency. And this abbreviation stands for PLP binding protein. We really know very little about the basic biochemistry of this binding protein, but we suspect that it binds pyridoxal phosphate and helps to move it around the cell so that it can do its job in being a cofactor in all of these important biochemical reactions. That's about all we know at this point, but we know that in this disease, there's a deficiency of that binding protein, and that's what leads to the neurological problems in these children. I should also note that this is also known in some publications as PLP homeostasis protein. So can be a little bit of confusion when you're reading about this. And then lastly, we have a condition known as PMPO deficiency. And this is actually a disorder of the synthesis of the active form of vitamin B6. And so, in other words, it is an abnormality of this enzyme here and here, which interconverts pyridoxine phosphate into PLP or pyridoxamine phosphate into PLP. And so when this enzyme is missing or functioning abnormally, again, there is a deficiency of PLP, and that is the nature of PMPO deficiency. So all three of these disorders may be suspected clinically, and generally that is because a infant or a young child presents with intractable seizures that are not being controlled by conventional methods, but then do come under control when pyridoxine or pyridoxal phosphate is provided for the patient. But really, to confirm the diagnosis, one must do laboratory confirmation with either the detection of certain chemicals in the blood or spinal fluid or urine that we call biomarkers, which are reasonably specific chemicals that may show up in one of these conditions, or more specifically doing DNA gene testing to document that there are abnormalities in the DNA that thereby prove that one of these three disorders is present. So by way of definition, I want to make sure that everybody understands the terms genotype and phenotype. When we use the term genotype, we're really talking about the changes in DNA that are present in a particular gene that we know when it's abnormal can cause a disease. And each of us inherit one copy of a particular gene from our mother and another copy from our father. And so when we talk about genotype in a particular patient, we're talking about the DNA code for a particular gene in the maternal copy, as well as the code in the paternal copy, and that's what we call the genotype. Phenotype, on the other hand, is what we are able to observe on a clinical basis. So in other words, if somebody has a change in their genotype, a change from the normal expected genotype that results in a disease or in a change of a function of a protein, for instance, then there are going to be some characteristics that we would see clinically, such as seizures or abnormal biochemical patterns, or abnormality in brain development, or a specific hair color, or an abnormality in hemoglobin, or a wide variety of different conditions. And it's those clinical features that we call the phenotype. And that's really what the rest of this talk is going to be concentrating on, is the phenotype of pyridoxine-dependent epilepsy. Now, another important concept is the concept of genotype-phenotype correlation. And that really is the association between a particular person's genotype and the pattern of the clinical features that he or she might have. So in other words, if a patient has inherited a certain pattern of DNA from mother and another pattern from father, and they're both abnormal and can give rise to a recessive condition, in some particular disorders, one can predict from the changes in the DNA pattern what the patient's clinical disease will look like, what the natural history might be, how severe it might be, et cetera. And that's called a genotype-phenotype correlation. And unfortunately, for the most part, we do not have that knowledge when it comes to the three forms of pyridoxine-dependent epilepsy. We know a lot about the genotypes. These have been well researched in the three forms of PDE. We are acquiring a lot of natural history information about these three different disorders, but there really is not a very good understanding of how a particular change in the DNA leads to one set of symptoms, in other words, phenotype versus others. So this is an area of research that will obviously continue, and hopefully will provide us with helpful information at some point in the future. Now, as far as the general clinical phenotype of these three forms of PDE, I think that the most recognizable feature in these diseases is that these patients present very early in life, sometimes even during fetal life, with seizures that have very little or no response to traditional anti-seizure medications. Most of these children will present within a few hours or days of birth, sometimes a few weeks. And as I mentioned, it can occasionally present during the last trimester of pregnancy, where a mother might feel some peculiar rhythmic movements on and off, which may subsequently be interpreted as having been fetal seizures. So this is the most common clinical feature of all three forms of PDE, is that these children have seizures that will not respond appropriately, if not at all, to anti-seizure medications, but they will come under control once they are given what we call pharmacologic doses of vitamin B6, either pyridoxine or pyridoxal phosphate. And when I use the term pharmacologic dose, I'm differentiating that from the term physiological dose. A physiological dose of a vitamin is really what we think of as the recommended daily allowance, the RDA. If you look on the back of a vitamin bottle, you'll see what percentage of the RDA might be contained in a particular vitamin tablet. And for pyridoxine, that RDA is generally around 2 milligrams a day, depending upon the age and sex of the individual. That's a physiological dose of pyridoxine, whereas a pharmacologic dose is substantially higher, on the orders of 100 milligrams or more per day, in order to get adequate control of seizures. It's important to remember that in the PNPO deficiency form of this disorder, 60% of these patients actually will not respond to pyridoxine, but must receive pyridoxal phosphate. Pyridoxine just does not do the job. Whereas in the other two forms of PDE, either pyridoxine or pyridoxal phosphate will be effective. These patients require lifelong treatment with vitamin B6 in order to provide adequate intracellular amounts of the vitamin, specifically pyridoxal phosphate. And in some instances, some patients may actually still require anti-seizure medications. And the reasons for this are really multifactorial, and we'll discuss a little bit about that in a few minutes. But for many patients, pyridoxine is all that's necessary to prevent future seizures. And then the last sort of general feature that is present in all three of these conditions is that there is some degree of neurodevelopmental disability in all three disorders. It's really quite common, as we will see. So what about the biochemical phenotype of PDE? Well, as far as PDE ALDH7A1 is concerned, which, as I mentioned before, is the best understood of these three conditions, we now know that there are some reasonably specific biomarkers that can be detected in urine, blood, or spinal fluid. And again, what I mean by a biomarker is that this is a chemical that can be detected through laboratory techniques, which is generally not present in an otherwise normal, healthy individual. But when it is present, is highly suggestive that a patient has PDE ALDH7A1. And the four biomarkers in question are AASA, P6C, 6-oxo-PIP, and something known as 2-OPP. And these are substances that can be measured in a research laboratory, and then some of them are actually now being assayed in commercial laboratories that a physician can send a specimen to for confirmation of this disorder. Now, this isn't the case for the other two forms of PDE, specifically PDE, PLPBP, and PNPO deficiency. There are metabolic features in these patients, and you can see changes in a variety of chemicals that are traditionally can be measured in reference laboratories, certain amino acids, certain organic acids, neurotransmitter profiles, vitamin B6 profiles, etc. But these are not really specific. So in other words, you can't take a urine specimen or a blood specimen and send it off to a lab and expect an answer to say, oh, this is a pattern that is diagnostic of PNPO deficiency or PDE, PLPB, for instance. It could be suggestive evidence of a disorder like that, but really does not make the diagnosis. And only by gene testing and obviously by clinical suspicion in a child who is having intractable seizures that then respond to vitamin B6, those are really the only ways of confirming the diagnosis. So what about the clinical seizures? What is the phenotype of the clinical seizures that these children have? Well, they're really quite diverse. And I think this is an important point for neurologists and neonatologists who are evaluating these young children, because there really is not a particular type of clinical seizure that we might see that would lead us to say, oh, this baby has a form of pyridoxine-dependent epilepsy. Really, the types of clinical seizure manifestation are similar to many other types of neonatal epileptic conditions. These babies can have stiffening events, something we call a tonic posture, where the torso, the arms, and the legs are quite rigid. They can have rhythmic movements of their arms, which we call clonic activity, where the arms or the legs or arms and legs simultaneously will be jerking in a fairly rhythmic uh, behavior. So in other words, a jerk every second, a couple of jerks every second in a very regular type of rhythm. But they can also have what we call arrhythmic movements, which we term myoclonic movements. And in this case, these movements are sporadic. They're usually very chaotic, but they're not occurring in any kind of predictable fashion. Uh, these patients also can develop a very critical situation known as status epilepticus, which are prolonged seizures that just do not stop, or if they do stop, they evolve into what we call serial seizures, where the clinical seizure may stop for 10, 15 minutes, and the patient does not return to a normal level of consciousness, and then a second seizure, then a third seizure develops subsequently. And this is truly a medical emergency. And in the case of a neonate with status epilepticus, uh, lots of different medications are tried to attempt to stop the seizures. But really, the only thing that's going to be beneficial would be an intravenous dose of pyridoxine. And then lastly, as I mentioned a few slides ago, in some circumstances, mothers may retrospectively recount that their fetus was having seizures during the final weeks or months of pregnancy. Now, what about the electroencephalogram? Well, the electroencephalogram is a clinical test where we measure the electrical activity of the brain, specifically looking at the activity that's being generated by the cerebral cortex, which is the sort of outer surface of the brain that where the electrical activity can be detected from electrodes that are temporarily affixed to the patient's head. And so there are a wide variety of electrical changes that can be seen in the EEG in patients with PDE. And again, it's important to emphasize that there really is no one specific pattern of abnormality that would clue a neurologist or a neonatologist into the possibility that a particular patient has pyridoxine-dependent epilepsy as the cause of their seizures. That doesn't discount the importance of getting an EEG, because many of these patients early on may have what are called electrographic seizures without clinical features. In other words, their epilepsy is so severe that you may not see anything clinically because they've had so many seizures ongoing, but only by connecting them to an EEG machine and monitoring their EEG for hours to days at a time will you realize that they're having many electrical seizures, even though you're not seeing them on a clinical basis. And the use of EEG is also extremely important when you're trying to make a bedside clinical diagnosis of PDE, specifically if a baby is having recurrent seizures that are not controllable with phenobarbital, with phenytoin, other anti-epileptic medicines. The EEG is generally hooked up so that the response of a medication can be seen both clinically by looking at the baby, but also electrographically by looking at the EEG. And in this circumstance, by administering pyridoxine, one might see something like this. And this is a patient who I diagnosed back in the late 1980s, early 1990s, long before we knew what the abnormal gene was in this disease. But here you can see an EEG that's ongoing in this baby who was a few months of age by then, with very abnormal activity here, quite characteristic of an ongoing seizure. The infant was given some intravenous pyridoxine, 5 minutes later, we have this segment of EEG that we can see where the abnormal spiking activity is reduced. The overall frequency of the EEG is slowing down. And then 5 minutes later, 10 minutes after the administration of the pyridoxine, the EEG is really quite quiet, and indeed it's actually quite suppressed. And this baby's EEG remains suppressed for a good 24 hours. And so it's important to realize that when pyridoxine is given intravenously, it should be done in an intensive care unit setting, because sometimes these patients can have such a profound reduction in overall neurologic function that they require very close attention until their brain starts to wake up again. And the hypothesis is that these patients have seen very little pyridoxine in their lives because of the underlying disorder. And this administration of pyridoxine is sort of the first appearance of this of PLP in their nervous system, which ended up suppressing everything for a good many hours before normal rhythms started to recur. So what about the other neurological features of these patients? And neurologically, we use the term encephalopathy. And this, as I mentioned earlier, is a term that means that there is abnormal function of the brain. That's all the term encephalopathy really means. And so it's not just the seizures that these patients are having, but they're having other neurological signs and symptoms, which are really quite important to recognize. And in the case of PDE, some of these encephalopathic symptoms are quite characteristic and may actually give a neurologist or a neonatologist some inkling that that the patient may actually have PDE, and can help you think of the diagnosis. And these are sort of periodic symptoms that come and go in these babies, that may precede by a few minutes or even a few hours before they have a very serious episode of seizures. And it may be the baby is at baseline, but then starts to have some periods of time where they are less aware. They may be profoundly depressed and be in a situation like stupor or coma, or they may just be profoundly sleepy. Alternatively, they may be very irritable and have inconsolable crying for 30, 60 minutes, that nothing will calm them down. They may be very jittery, in the sense that if you touch the baby, they might get very rigid and then shake their arms and legs for a couple of seconds before that calms down. They may have what's termed as a hyper alert expression to their face, where their eyes are wide open. There may be some grimacing that goes along with this as well. Their eye movements may be quite peculiar. They may not have fusion of their eye movements, but their eyes may wander off in different directions before coming back into normal alignment. And then they can have fluctuations in the tone of their trunk and of their extremities, where they may have normal tone 1 minute, they may be very floppy and hypotonic another, they may be rigid another. So seeing a variety of these neurologic symptoms, these encephalopathic symptoms, may be very helpful in leading one to a diagnosis that there's an underlying metabolic cause for the baby's seizures. I think it's also important to point out that PDE is, in some respects, a systemic disorder. So it's not just a brain disorder, but there can be abnormalities in other physiologic functions. And there are many reports that when these babies are born, that there may be some elements that are suggestive of what we call intrauterine fetal distress, or sometimes termed hypoxic ischemic encephalopathy or neonatal encephalopathy. That's not to uh, presume that these babies have had abnormal blood flow or decreased oxygen or some type of obstetrical um, problem. It's just that the condition of these babies, the symptoms that they have, are very similar to a baby who may have had these abnormalities during delivery. They may present with respiratory distress, which again, can certainly be seen in premature infants, for instance, or infants with congenital heart disease or congenital lung disease or infection. So again, it makes one think of other diagnoses if one's not thinking of a primary neurologic etiology. Their feeding may be abnormal. Again, this is probably due to just abnormal neurologic function, that they're unable to suck and swallow adequately. And in turn, they're not going to gain weight very well for that same reason. And then there have been some descriptions of these babies having distension of their abdomen. And again, it may just be due to what we call sympathetic nervous system abnormalities. In other words, the nervous system's ability to control digestion and flow of nutrients from the stomach to the small intestine, etc. Now, what about the neurodevelopmental phenotype? As I implied earlier on, a large percentage of these patients, no matter which form of PDE, are going to have some type of neurodevelopmental challenges. And as far as PNPO deficiency is concerned, about 60% of these children are going to have some form of developmental impairment involving speech development, cognition, and or behavior. And in patients where the diagnosis was made later during infancy, in other words, these infants had many seizures for weeks and months on end before diagnosis was considered and vitamin B6 treatment was initiated. There is certainly concern that the later the diagnosis and treatment is made, this will lead to a more severe, concerning neurodevelopmental challenges. As far as PDE, PLPP is concerned, we have less clinical information about these children. The number of patients who have been described in the literature is relatively small, but what we do know is that over 50% of them also have neurodevelopmental problems, including learning problems, low tone, and variable difficulties with speech development and overall motor development. And then we get to PDE ALDH7A1, again, the disorder that has been the most studied and certainly the disorder that I'm best familiar with. And these patients, about 75% of them are going to have some degree of developmental disability. And this really ranges from relatively mild intellectual or behavioral or language problems to some rather concerning and severe deficits, including autistic features and very severe behavioral problems. And as with PNPO deficiency, a late diagnosis, late initiation of treatment may certainly be associated with more severe neurodevelopmental problems in the future. Interestingly, we do know that there are about 20% or so of patients with this form of PDE where their seizures actually begin later during childhood, or even in, or should say later during infancy, or even during childhood, or possibly even during early adolescence. And why this is, we don't know. Again, we don't have a genotype explanation for this. I personally know a pair of brothers where one brother had seizures that began at birth, and the other brother had seizures that began at 9 months of age, and they have the same genotype because they inherited the genes from the same pair of parents. So the explanation for why one of them has late onset seizures is really unclear. But we do know that the patients whose seizures begin later during infancy seem to have less challenges with their development. And then lastly, to emphasize the research that Dr. Kaufman and I and several of our colleagues have been involved with over the years, we now have been able to show that if one provides lysine reduction therapies, in other words, a metabolic directed dietary therapy to these patients, and if it's been initiated by 6 months of age, there will be a statistically improved neurodevelopmental test scores in these patients. So making an early diagnosis and initiating prompt metabolic therapy is certainly very important. So the last thing I'd like to talk about is what I call the anatomic phenotype. This is an area of research that I've been particularly involved in. And as far as all three of the conditions are concerned, it's important to understand that a patient who has frequent and prolonged seizures, particularly early in life, and if these have been occurring frequently, prior to an accurate diagnosis and specific treatment, this can actually lead to what we call acquired changes in brain structure. And so I need to differentiate the difference between an acquired change in brain anatomy and a congenital change in brain anatomy. A congenital change means that it occurred during fetal and early postnatal life. In other words, you're born with this change in brain structure. Whereas an acquired abnormality is one that develops because of a what we term an insult to the brain as the brain is developing, whether it's an infection, whether it's ongoing seizures, whether it's due to trauma, etc. So in the case of all three forms of PDE, we know that in children who've had many poorly controlled seizures, that they are at risk for developing a progressive loss of brain substance. And this can be seen either as what we call microcephaly, which means that the circumference of the head is smaller than what we would expect for a particularly aged child. And they can also develop what we call hydrocephalus, which means water on the brain. Hydrocephalus means that there is decreased overall brain tissue, and instead of seeing brain tissue, we see fluid in areas which where, or I should say, too much in certain areas of the brain where we normally do see some fluid, but there is too much fluid being present. So the fluid is taking up the space where the brain tissue may have been. Another acquired change that we might see is what we call mesial temporal sclerosis, or atrophy of the hippocampus. And the hippocampus is a very important portion of the temporal lobe, which is present both on the right and left side of the brain. It's very important for the development of memory. And it's also an area of the brain that, if injured, if scarred, can actually be a reason for difficult to control seizures. And we do know that in, again, young patients who have had many seizures, there can be sclerosis or hardening of the hippocampus and otherwise loss of tissue in that region, which can lead to a future challenge with the overall treatment of the epilepsy. So these particular acquired changes may actually be an explanation for why some of these patients still need anti-seizure medications in order to have reasonable control of their epilepsy. In other words, the pyridoxine is just not going to do the whole job. The seizures are still occurring in some certain circumstances, and one or more anti-seizure medicines is necessary. And it may very well be due to scarring in the brain or other changes in the brain that may be present. So here's a couple of examples. This is a patient who I took care of also in the 1980s and 1990s, who was unfortunately, not diagnosed until 8 or 9 months of age. And as you can see, this is what we call a sagittal view of his brain at birth. And this is a view at 8 months of age, just around the time that a clinical diagnosis was made. Again, there was no gene testing, biochemical testing available in the 1980s. And what we can see here, if we look at the right-hand figure, is that this black space here is what's called the lateral ventricle. And then this area here is the fourth ventricle. This area here is the cerebellum. And if we compare these black spaces to what we see on the left-hand frame, which was the birth MRI, we can see that the lateral ventricle is substantially larger. The fourth ventricle is also larger. And this is a suggestion that there has been some loss of brain tissue and an increase in the fluid-filled spaces, sort of taking up the space that had previously been occupied by normal brain substance. Now, as far as mesial temporal sclerosis and hippocampal atrophy is concerned, that can be seen in this MRI scan of a particular patient. And this is a different pulse sequence. And in this particular MRI, the fluid-filled spaces of the brain is actually white as opposed to black. So we're again looking at the lateral ventricles. This is a coronal version of the brain. So it's as if we are looking at this patient head on. And we can see the right and the left lateral ventricle here. And if we look at this little area here, I'm sorry, I misspoke. If we look at this area of the ventricle here, the lateral ventricles also come down onto the temporal lobe here and here. This is the temporal lobe. This is the left temporal lobe. This is the left temporal lobe. Excuse me, the right temporal lobe here. The lateral ventricle comes and sweeps around the temporal lobe here and here. And normally you should not see this much white in a coronal MRI scan. So this suggests that the hippocampus, which is this curved structure of the temporal lobe here and here, is somewhat atrophic, meaning that we see more fluid around its exterior than we should see. And also, very subtly, there's some signal change within the hippocampus, which tells us that it is sclerotic. In other words, it's scarred. And so, these abnormalities in the hippocampus can give rise to additional reasons for having clinical seizures, which would not respond to pyridoxine. Now, besides these acquired explanations, these acquired features that can develop in the brains of these patients, as I mentioned, there are some congenital abnormalities of brain development, which are also, I don't want to necessarily say it's characteristic per se, but are common in patients with PDE due to ALDH7A1 deficiency. One of these is what's called a megacisterna magna, and I'll show you a MRI of that in just a second. The cisterna magna is a normal fluid-filled space at the back of the brain above the cerebellum. And it's a finding that's present normally in about 1 or 2% of individuals. And so somebody may get an MRI scan for whatever reason, and they may have a megacisterna magna, and it's usually of no consequence. But in the case of PDE, ALDH7A1, it's present in about 18 to 20% of these patients. So this, again, is a developmental feature. It's there when these babies are born. It's not a consequence of having too many seizures in the neonatal period or during early childhood. The corpus callosum is a very important tract in the brain that connects the right and left side of the brain. And work that I've done with my colleagues in Seattle has demonstrated that the corpus callosum is normally very thin in patients with PDE, ALDH7A1. And again, it does not depend upon when the MRI scan was done, how late during infancy they may have been diagnosed and started on treatment. This is a congenital feature of this disease. And if one looks very carefully at the corpus callosum and uses quantitative techniques, which are not typically done when an MRI scan is being interpreted by a radiologist, one can actually show that the corpus callosum is abnormal in almost all of these children. And then lastly, in very infrequent circumstances, there may be other abnormalities of the way the brain was formed. And these are changes in the brain known as heterotopia or cortical dysplasia. And this is abnormal migration of various neural cells during usually the second and third trimester of brain development, where these nerve cells do not end up in the correct portion of the brain. In other words, they're sitting in the wrong part of the brain. And these heterotopia or these dysplastic areas of brain are another reason that these patients may have ongoing seizures, which again are not going to be controlled with vitamin B6. They require the use of an additional anti-seizure medication. There have been very rare occurrences of congenital cataracts in these patients. I know of a couple of reports in the literature that have described this. We don't know exactly why that might be the case. And then lastly, just to leave you with this, in my experience in having the privilege of seeing somewhere around 25 patients with PDE, ALDH7A1 over the years. Not that I've diagnosed or managed all of these children, but they've come to see me for an opinion. I've noticed that there are some subtle facial features which I personally think are somewhat characteristic of this disorder. Again, it's not something where you can look at a patient and say, "Oh, this patient has PDE." It's not as recognizable as, for instance, a child with Down syndrome, for instance, where their facial features are quite characteristic. But I do believe that there are some features that may be shared by many of these children. So here are a few MRI scans just to show you what I've talked about. Megacisterna magna, again, is this area of fluid that is present behind the cerebellum. Again, this is the cerebellum here at the back of the brain. This is the brain stem and the spinal cord. And this is the cisterna magna, which is a normal fluid-filled space. And the megacisterna magna is one that is quite large, as in this patient. And again, this is a normal finding in about 1 to 2% of individuals, but seems to be present in about 18 to 20% of kids with PDE, ALDH7A1. The thinning of the corpus callosum, as I mentioned, is something that I feel is really present in every patient. If one looks at the corpus callosum in a very specific and quantitative fashion. In this particular instance, the thinning is really quite obvious. And it's usually in what's called the isthmus of the corpus callosum. Again, the corpus callosum is this white matter structure here in the middle of the brain that connects the right and left side. And this portion here, the isthmus, is pinched in this particular instance. And again, in all of these patients, we do see some thinning in this area, this being a very obvious example. And then lastly, this is a patient who has evidence of a heterotopia that could be another focus of seizures, which would not be controllable with vitamin B6. And again, we're looking at a coronal view of the brain. We're actually sort of a good 2/3 of the way back through the brain, looking at the sort of the back third of the brain face on. Again, these are the lateral ventricles. And you can see that there's this little bulge here and this little bulge here. That's normal. It's a portion of the caudate nucleus. But then here, there's another little bulge, and that shouldn't be there. And this is an abnormal area of gray matter. These are neurons that should be somewhere out here if they had developed normally. But for some reason that we don't necessarily fully understand, when these neurons were generated, early on during fetal life, instead of moving out, excuse me, and instead of moving out and landing somewhere here in the outer portion of the cortex, they stayed put here in what's called the periventricular region and did not normally migrate. And cells such as this could represent a seizure focus and give rise to seizures that will not respond to pyridoxine. Again, this is a congenital abnormality. It's not something that developed later on during life because of poorly controlled seizures. Lastly, as I mentioned, I'll leave the end of this talk to just show you a few photographs. I feel that there are a few facial features in these children which may be common in many of these patients with PDE ALDH7A1. And in the children that I've seen over the years, I've been struck by the fact that they have a rather high hairline and a very prominent forehead. They may have some subtle changes in the shape of their nose, where the top of the nose may be somewhat broad, the tip of the nose may be prominent, the nostrils may be a little bit small, and the tissue that separates the two nostrils, known as the columella, may actually be somewhat prominent. As far as looking at their eyes are concerned, their eyebrows may be somewhat full. Their eyes are sometimes widely spaced. And then lastly, their face tends to be somewhat long, and their chin may be a little bit pointed. And what I was able to do was to get access to artificial intelligence website that actually can generate images of individuals by just putting in a variety of these facial features, and then a fictitious face is generated by AI. And I'm just going to show you a few examples that were generated by this website, just to give you an idea of what these children, the facial features that may be present in these children. And again, these are not photographs. These are not real patients. These are AI generated faces using these clinical features. And I think you can clearly see the rather high hairline that these children have, the broad forehead, the somewhat elongated face and pointed chin, things of this nature. And, I don't pretend to think that those of you who care for a child with this disease, whether your child has these features or not, that's for you to decide. But it's something I've observed over the years in having the privilege of being able to evaluate these patients and have conversations with their parents. So I apologize for going over. I'm really sorry for the technical difficulties. I truly don't know what happened, but I'm glad we solved it. And I'm glad to take any questions.
if nobody's jumping to ask a question, I'll get straight in there. But first of all, I must say thank you very much for your time, Dr. Gospe. It's really appreciated by this community, and it really means a lot to hear from people like yourself that have been working on this condition for as long as you have. So, thank you so much for taking the time to talk to us. I had a question with regards to hydrocephalus. My son Jack, who's 2 years old now, he's been quite unfortunate with the condition. He's had 8 revisions of his shunt fitted to control it. But really, you described it as a loss of white matter, of brain matter. Whereas my layman's understanding was more that it was a blockage that caused the cerebral spinal fluid to increase the size of the ventricles and compress the existing brain matter. And the MRIs that Jack's had performed would seem to sort of suggest that, because the white matter, once his shunts are resolved, the blockages are resolved, and he has a new one fitted, the white matter returns and his ventricles return to a sort of normal size. Am I misunderstanding something, or is that a different presentation?
Yeah, absolutely not. You're correct, and I failed to mention that there are other instances of obstructive hydrocephalus in this disorder as well, and that's indeed what you're describing with your son. So,
got it. Okay, just making sure that we're talking about the same thing.
Yes,
Thank
absolutely.
you.
Yes.
I have a question. So my daughter, she was just recently diagnosed with PDE a few months ago, but she's been having having seizures since she was maybe about a week old. And they, pretty much didn't know what was going on. So she was on anti-seizure meds for a long time. But a few of the times that she had her hospital stays and they were doing EEGs, she clinically looked like she was having a seizure, but they kept saying it wasn't showing on the EEG, so it didn't look like a classic type seizure. So is it likely that the seizures of PDE that they won't show clear on an EEG, or
Sure.
how would it look?
So as I mentioned, when you are performing an EEG, you're only looking at the electrical activity of the outer few millimeters of brain tissue. So it's certainly possible that electrographic changes are occurring deeper in the brain, which are not going to show up on the EEG, or these episodes that your daughter is having may represent features of the encephalopathy. In other words, the abnormal facial movements, the peculiar eye movements, things of that nature, which clinically could be interpreted as a seizure, but which one is not able to correlate when having an EEG running at the same time.
Okay. Thank you.
You're welcome.
I have a question.
Please.
In adults, I'm a care or an advocate for 2 adults here in Ohio. One of them is 64. One of them is 69 years old. The oldest one, they were suspicious of them having this at birth. They both seized pretty severely at birth. They started her immediately on treatment, and she's not as severe as her brother, who for some reason they thought didn't have it as he was seizing for 6 weeks. So they didn't start his treatment. My question is, we just officially got them diagnosed through genetic testing. They have not had great treatment all of these years, very low doses of B6 or paradoxine. We are now doing a lysine reduction diet on them. Is there any research that shows any benefit to a lysine reduction diet in adults?
I don't know of any data that would suggest that. Dr. Kaufman certainly might want to chime in here if he knows of anything in the natural history study that would speak to much older patients and how they may have responded.
Okay.
Yeah, I think it's a good point to remind everyone that I don't want to speak for Dr. Gospe, but I'm always happy to talk to people's physicians because these really are like individual physician-patient decisions. And I actually do believe I've spoken to their physician in Cleveland.
Maybe you have, yeah.
So I don't know, Dr. Gospe, if that's an accurate statement that if you're a neurologist or your metabolic physician wants to reach out to us, I know that I'm always happy to talk to your child's doctor. Dr. Gospe, I assume that's still true for you.
Yeah, it is. I never reach out to someone cold. In other words, if a family says, "Could you call Dr. Jones for me?" And I'm not going to do that. But if Dr. Jones calls me, then I will certainly speak with Dr. Jones.
Yeah, and so grateful that your doctor reached out. What I will say is that there is some anecdotal evidence for adults being on some of the lysine-related therapies. Sometimes it's the higher dose arginine that people have used, and what they have reported is that there's been some changes in behavioral problems.
We're seeing that.
I-
We're seeing that. Yes.
Yeah, so and it's really interesting data. I've heard it from families that are in their 20s and 30s and 40s. Actually, this will be the first patient I know who's tried it a little older than that. But I do think these are hard decisions to make. They're individual decisions based on like how hard it would be to go on these diets. Dr. Gospe referred to the work that we've done together and really showed that treatment in the first few months of life, we had like documented reasons why it helps. And older, it's hard to know. Does that
Okay.
seem, what do you think? Do you agree with that, Dr. Gospe?
Yeah, absolutely.
Okay. It's hard to know. We don't have the research yet that really proves anything. Okay.
You know, as I mentioned to your doctor and to all of you, we'd love to continue to collect that data. Dr.
Mhm.
Gospe and I are part of a large natural history study. And
Yeah, so we would love to keep giving you the data and whatever you would like, because to help other people through them would be wonderful. But we were curious. I know Chris, the female, is having a very difficult time with this diet, and but she even notices herself. She's more cognitively, she has less cognitive impairment, so she can communicate a lot better with us. But she has noticed, she said her head feels clearer. She said, I feel clear. And we noticed, she said, I have more energy. I feel good. She didn't feel so good all the time. So we have seen those changes. But now, what is doing it? Her higher dose of B6, the arginine, or the diet? We don't know. You know. Okay, thank you.
just really excited to hear that she says she's doing better no matter what it
Yes.
is. It's exciting.
Yes, yes.
Exactly. Any other questions?
Hi, I have a question.
Go ahead, Carly. Sorry. Yeah.
Okay, sorry. When you said autistic traits, I was just curious if like autism, I know sometimes can go hand in hand with epilepsy itself. I know this is a little bit different, but is it just traits or is it like, are they autistic?
Well, I think, the definition of autism is a clinical definition. So in other words, if a child or an adult has certain behavioral features that may allow one to make a diagnosis of autism. And certainly there are patients with PDE who have a variety of behavioral features where a diagnosis of autism is certainly appropriate.
Okay.
I think it's important to remember that autism is a syndrome. There is not just one reason that a patient has autism. There's one reason why somebody has PDE ALDH7A1. They have changes in the two copies of that gene, and that's why they have the disease. There is no one reason why somebody might have autism, and PDE is one of those reasons, but there are many others.
Okay. And then last quick question. I'm also located in North Carolina and we do go to Duke Children's Hospital. The teachings that you do there, are they open to the public or is it just for the doctors and stuff?
I just have lectures with the residents.
Okay. Okay.
And I certainly know your who's taking care of your child in all likelihood. I'm no longer seeing patients, but I could certainly, come in when I could be called in to meet you if enough advance warning is given when you're coming in to be seen. I'd be glad to come and meet with you.
Okay, amazing.
Yeah.
Thank you.
You're welcome.
Since Anastasia brought it up at the start of the meeting, I was wondering is there a higher prevalence of strabismus with PDE, and is it always down to underlying neurological conditions, or is it could it be just typical strabismus?
I think it's hard to ignore the underlying neurologic disease, and one would have to say that the strabismus is a part of the phenotype in your child, as I heard you discussing this earlier on. So I think that, yes, he could possibly have strabismus for some other reason, but in all likelihood, it is a clinical feature of his PDE.
Right. And if that's the case, is there at any point in pursuing typical treatment, corrective treatment as they would with traditional strabismus?
Well, I think that's really up to the ophthalmologist who, has to quantify the degree of malalignment, how well the child is, how well their vision is maturing, because the whole concern about untreated strabismus is that you can lose visual acuity,
Right.
and wants to address that as early as necessary.
Got it. If there's no other questions, final question from me, and I'll stop bothering you. Thank you. What do you see as the most sort of promising therapeutic tool being developed, and where are you thinking that's going to go?
Well, again, I'm going to bounce this back to Dr. Coughlin, because he is very active with the research group primarily in Europe, and I think just returned from a meeting back there, so he can possibly give some more up-to-date information than I'm certainly able to, because I'm somewhat out of the loop these days in that regard.
Yeah, I think Curtis has given us an update in previous meetings with regards to what he considers to be promising treatments, though probably didn't have as much time as he could have had available to discuss that topic, right, Curtis?
Yeah, I mean, certainly, I think we're all excited about the treatments that are coming from a scientific perspective, and all of them are too slow and not exciting enough from a parent perspective, but be happy to talk about them another time.
Anything that this community can do to support the development of those treatments?
Absolutely, and I think you'll be hearing from Anastasia and Anna about that in the future. So, but I think so. I don't want to speak for the community. I will say, I know we've mentioned a little bit about the Charlie study that's going on for therapies, and we have a series of 7 podcasts that are coming out on sort of what we're doing and what our data is. The first one is myself and Dr. Clara Van Carnabeek just talking a little bit about why this group of people has come together, and why we're approaching the therapies in the way we are, why we don't have an enzyme replacement therapy, but we have other ones. And so I certainly, as soon as those are out, I will share those with Anastasia and Anna, and hopefully they will share with the rest of the community.
Fantastic. Thank you.
Absolutely. Maybe we'll do a separate webinar on therapies that are currently in the works. Any other questions?
Yes, I have just 2 more quick questions. First question, for when you may mention about like neural development, like late development, could that still affect if like my daughter, she was on anti-seizure meds for the first 3 years of her life, but she didn't start the pyridoxine treatment until a few months ago. So given that she had all of that time without it, could that still affect with her developmental like delays?
Well, I think that late diagnosis and late therapy can be a risk factor for problems with development. So as I mentioned earlier, and again, it all depends on unknown aspects of the genotype and possibly other genes that we are not at all aware of that could be modifying the phenotype in a particular child. So I don't want to say specifically that because your daughter was not diagnosed or treated until a certain time period that her development is going to be impaired in a certain way. It's concerning, but there's still many things that we don't fully know.
Okay. Thank you. And then one more question for the abnormalities in muscle tone. I do notice, like, from the time that she was hospitalized, she kind of regressed in a lot of her mobility as far as like walking and movement and that such. So could that been from just her being sick, or from the just multiple seizures that she had in the hospital?
Well, I think it's a combination of everything. So, but again, I think the uncontrolled seizures probably have a lot to do with that. But then again, they're certainly well recognized that motor challenges can be present in many of these children, even if they only had a couple of seizures in the first week of life, and then a diagnosis was made and they never had another seizure. So again, the phenotype is broad, and we can't necessarily come up with one explanation.
Okay. Thank you.
You're welcome.
I just had one quick question. My son had his last EEG at about 9 weeks old when he got diagnosed with PDE. Would you recommend if I pushed for that through our neurologist? Like, he's off all seizure med, and he doesn't do any like abnormal movement stuff, but could he be having seizures that we're not seeing?
Generally speaking, an EEG is performed for about 20 minutes. And if a patient were having subclinical seizures, occasionally, the likelihood of you picking it up on just a routine outpatient EEG extraordinarily small. And I think that, if a child is not having any clinical seizures, if their development is progressing, they're not having, episodes where their behavior seems to change, where they, have excessive sleepiness or changes in tone or irritability, et cetera, et cetera. I personally do not recommend getting more EEGs. Again, it's an EEG is a snapshot. It's not going to tell you what's going on with brain function for a prolonged period of time. So one can be in certain circumstances might be falsely reassured that there's not a problem. If you get an EEG at 10 in the morning and the EEG was going to be abnormal at 10 at night, I mean, as an example. But for a patient who's not having any clinical seizures, who's developing at a particular rate without any overall deterioration, I don't think that repetitive EEGs are clinically indicated.
Okay, thank you.
You're welcome.
Thanks, Dr. Gospe. I think we might call it a day. Also, respect for your time. Thank you so much. I will post the recording on the YouTube page. I'll trim it a little bit so we get some of the kerfuffle out. And just for everybody, please sign up for our newsletter. If you want to follow along with other webinars, feel free to jump on. The next one will be more of a community focused one. So we'll let you know what we're planning for that. If you have any thoughts, always email us. And also don't forget, we're going to try to get some families together in October. I posted the registration link. If you have any questions, just email us. And yeah, thanks everyone for coming. And it was nice to hear from some new folks, and we hope to see you on here next time. Thanks, Dr. Gospe.
Thank you. My pleasure.
Bye, everyone.
Thank you so much.
Thank you.